Hi. Yes, I should also mention that Todd Munson was my fellow practicum advisor. His name, I left his, anyway, I want to give credit where credit is due. But anyway, I'm going to talk about operations research. I think I might be the only operations research person in the room right now, so please bear with me and I'll try to be kind and be application focused. I got rid of almost all my equations. But at any rate, first I want to start off by talking about what I mean when I talk about public health emergencies. I'm not focused on things like fires or earthquakes here, but instead I'm thinking about medical emergencies. Things like naturally occurring events such as pandemic flu or bioterror attacks such as anthrax, smallpox, botulism, all sorts of very scary things. Now, one of the challenges of public health emergencies is that you need to be prepared for a wide variety of events, but many of them have never actually happened. And that's a good thing, but they're very unpredictable. You don't know when or where they could happen. And you have to have systems in place ready to respond very quickly to minimize mortality and morbidities in the population. So we can't afford to just ignore these events, but we don't have much experience dealing with them. So one solution to this could be to run lots of exercises. We could regularly practice the systems in place so that people know what they need to do when an event actually occurs. But exercises are extremely expensive. You need a lot of people and a lot of time. And the ones that are run are not very realistic. Usually all the people involved in a public health emergency response exercise are given lots of advance notice, and they basically have a very detailed plan of what they're going to do. So it's not a very good reflection of what a public health emergency would actually be like. So this is where modeling comes in. And we're trying to construct a wide variety of models to help public health authorities understand what might happen under the very uncertain conditions of a public health emergency. Today I'm going to focus on one of the models that I present in my thesis, which is related to inhalational anthrax. I'm going to tell you a little bit about the United States' current emergency response plans and present a multi-echelon or multi-level model for inventory allocation in this setting. And I'll talk just a little about some of the public health policy implications. So first, a scary little introduction to inhalational anthrax. Inhalational anthrax is something that you contract by breathing in a sufficient number of anthrax spores. Anthrax spores are very tiny. You don't know when you've inhaled them, and they're very difficult to detect in the atmosphere. Once you've inhaled spores, within about 2 to 7 days, you'll start to display some mild cold and flu-like symptoms. And shortly after that, your major internal organs fail, and then you die. It's not a good situation. Yes. Yeah, so this is the story. The good news, the one silver lining here, is that if you begin taking antibiotics before you start exhibiting those mild cold and flu-like symptoms, then your chance of survival is highly likely. So that's the good news. So the United States plan for responding to an inhalational anthrax attack, once one is detected, is to provide antibiotic prophylaxis or antibiotic protection to the entire population of some affected city or area within 48 hours. This is the network that's in place to carry out that operation. The Centers for Disease Control and Prevention, or CDC, has set up the Strategic National Stockpile, which sounds like we should be in the other room dealing with nuclear weapons. But actually, it's a stockpile of medical supplies and medications. And this is a stockpile that's owned by the government and ready to be sent out for a wide variety of medical emergencies. For instance, they have antiviral drugs that were sent out to deal with swine flu in 2009. For anthrax, they have ciprofloxacin and doxycycline. And these materials would be sent out to state-controlled receiving, storing, and staging warehouses, or RSSs. CDC loves their acronyms. I will try to avoid them when possible, but feel free to call me on it if I forget. RSSs are not meant to be long-term storage facilities for medications. They're not necessarily air-conditioned or ready for long-term storage, but they're just meant to be flow-through points. So inventory comes from the federal government, it's transferred into state control, things get broken down and repackaged and then sent on to local point-of-dispensing clinics. These are ad hoc clinics that could be set up in high school gymnasiums or community centers or other locations, and that's where we, the population, would go to pick up our courses of antibiotics so that we don't die from anthrax. So we want the system to work very well. But of course, I mentioned earlier, this system has really never had to operate within 48 hours, although we think that it can. But it's very important that we think carefully about the logistics of the network. Now, since the late 90s, when people identified anthrax as a really severe public health threat, a number of people have been studying this system. A lot of that work has centered either on very big picture, long-term modeling ideas, things like, should we invest in better anthrax detection technologies, or should we try to improve our hospital surge capacity? And then at the other end of the spectrum, other work has dealt with the points of dispensing, the clinics themselves, and thought about how can we make sure these clinics are going to operate as efficiently as possible to serve people quickly. My work is novel in that it looks kind of at a supply chain view and looks at this picture as a whole. We focused on the logistics of this network. I've had the good fortune to work with people in New York City, LA County, and the CDC. And we've heard a lot of interesting questions, which I address in different parts of my thesis. For instance, at the local level in New York City, the New York City Public Department of Health and Mental Health was criticized in 2009 when they were doing swine flu vaccination for not opening enough point of dispensing clinics. And so there's been some questions about how many pods is the right number? How many is enough? And so we've had some interesting talks to them about that particular question. Los Angeles, since they're dealing with a relatively spread out area, has a lot of questions about transportation and thinking about how often do you need to be sending shipments out? How can you improve your situation if you can reduce your lead times or your travel times from your warehouse to your clinics? And then everybody is interested in kind of the big picture questions of how do we make decisions about how much inventory to move around over time? How much information needs to be collected and shared between the different locations? And who should be making decisions? And these are big questions. And today I'm just going to talk for a few minutes about the inventory allocation question. Next, I'm going to be presenting a part of a model that I've developed here. So the model that I'm going to present here thinks about this system as a tree. We're condensing the Strategic National Stockpile, the SNS, down to a single location, which is not too worrisome because it's actually a very tightly controlled, centrally managed group of warehouses. So we're going to think about a time periodic model. And at the beginning of each time period, we know something about the state of the system. Don't worry about remembering the notation. I'll mention anything you actually need to know. But at the beginning of each time period, we know, for instance, what patient demands have arisen at our clinics in the past. We know the current queue lengths of people, numbers of people waiting outside each clinic. And we know the inventory that we have throughout the system. The decision we're going to make in this system is what inventory we're going to order up to. So basically how much inventory we're going to move through the network in each time period. And a time period would depend on your type of emergency, but for anthrax, for instance, a period might be 1 or 2 hours. So these are frequent decisions we're going to be updating. Now, of course, our decisions are constrained. We can't ship inventory unless we actually have it on hand. And we also don't allow inventory to be sent back up the network. There's 2 reasons for this. The first is just that if you're operating in an emergency scenario, it's unlikely to be willing to give back the supplies that you're going to be giving out to save lives. That's not usually states aren't eager to return materials to the federal government once they've received them. So, which is not an unreasonable thing to do. Also, there's just not the infrastructure in place to deal with returns. So once inventory has been sent down the chain, you can't get it back. And so you need to be a little careful about these decisions you're making. We also have constraints on transportation. And then once you've made your allocation decision, you're going to observe some random demand at your different points of dispensing, at your different clinics. You can't control where people are going to go. So we have some random number of little stick figures who will appear. And then a certain number of them will be served at each location. The number of served depends not only on the inventory that's available, but also on your service capacity. Your staffing plan is going to determine how many people you're actually capable of serving. And so some number of people are served. Now, our goal in allocating inventory here is that we want to minimize both the waiting time for patients. You don't want long queues of people waiting around for service. There's potential for panic. Anthrax is not contagious, but in a contagious illness setting, you'd certainly worry about disease spread. And also, we have this very strict time goal before we all start dying of anthrax. So it's very important we're efficient here. But also, we don't have an unlimited supply of inventory. We don't want to be wasting huge quantities of inventory that we could be using potentially to save lives somewhere else. So we have these they're cost parameters. These are not dollar costs, these are parameters. We use them to enforce these inventory goals. So we have a holding cost on inventory that we're holding at different locations at the end of the period, and a backorder cost on these backordered patients here, borrowing terminology from inventory theory. But we can now write this as a dynamic program. So if we let U be this feasible decision set, so that consists of all those constraints I described in words a little while ago, and we let C be our cost function, which is a function of our state space, we can write down, this is one of my only equations, we can write down a value function. So the value in period T as a function of our state that we described, we're minimizing over our feasible set. We want to minimize the cost both now and the expected future cost. But if you remember, each of these little state variables is actually a large vector. And so this problem is intractable, like so many dynamic programs that we actually want to be able to solve. What we do instead is construct two different approximate solutions. The first one is basically a myopic type of idea. In this setting, you're probably not going to want to send out large quantities of inventory in each time period. And so you can hope that your decisions now won't have long-lasting effects into the future. So we'll truncate the time horizon of the problem, make a few other estimations, and it allows us to simplify the problem so that we can actually solve it. The next possibility is to use a Lagrangian relaxation technique. For those of you not familiar, Lagrangian relaxation is basically an idea where you remove some constraints from the problem, which simplifies its structure and makes it possible for us to solve it. But instead of just getting rid of those constraints completely, we replace them with cost terms. So we allow ourselves to violate our constraints, but we charge ourselves a penalty cost to discourage our problem from doing that. And so we have this is a description of the process where we have several steps of relaxation combined with some restructuring the problem, and it allows us to decompose that very large, nasty dynamic program into a set of single variable dynamic programs that are easy to solve. So from that, if V tilde is our approximate dynamic program, we can actually make decisions using our original dynamic program where we replace the unknown future cost function with our now possible to calculate V tilde function. We compare these allocation methods to those that are actually in use by the public health system. By far the most common method for allocating inventory is to simply do so based on population. The states push out inventory to the clinics based on the expected population those clinics are serving. The SNS pushes out state based on population without actually looking at what demand is arising over time and where people are going and what's happening. So very little information has to be shared here, which makes it relatively easy to implement, and that makes it very desirable in some ways. The other method is actually slightly more sophisticated and allows different locations in the network to order for themselves. We ran a large set of simulation experiments, large number of replications for 23 different potential networks. And we showed, unsurprisingly, that our methods perform better than the two rather naive methods currently in practice. But what's key here is that we can quantify how much better. And we can provide public health departments with the material they need to say, it might be worthwhile to invest in better decision-making techniques and technology because, for instance, if we use the fair share method, the population-based allocation method, we can show easily that it's in any of our simulation experiments, it always requires at least 40% more inventory while providing 25% longer patient delays. So you have to spend a lot more money in inventory to provide much worse service to people. And so that's something that's been of interest and a little bit eye-opening to public health departments. Also from the public health point of view, we've shown a few things quantitatively, such as the fact that who's making your decisions is very important. Having a centralized command and control system is a really high value item that a lot of them are thinking about investing in. We're trying to prompt that a little bit further. Also, when talking to New York City, we can show that having a large number of pods can actually significantly increase the delays for patients and the wasted inventory that you have. So while they still may choose to open more clinics, they're going to want to think carefully about perhaps it's more valuable to bus people to existing clinics rather than opening a very large number. Also, very important to a lot of the public health people, is just the emphasis that we've shown that if you use one of the information-rich methods that I described, both of the methods that I proposed involve sharing a large amount of information among the different players in the system. And if you're able to implement one of those systems, if you actually have enough information available, then you can significantly improve the performance of your system without investing in greater inventory costs. And with that, I will wrap up and say thank you so much to my advisor, Jack Muckstadt, my collaborators at Cornell and Argonne, and especially to the Cornell Institute and the Department of Energy. Thank you.